Hi, everyone. Good morning. Tracy reached out to me asking me to speak about fundamental care in LGS. And I remember in one of our prep sessions, I was like, Tracy, I don't know, how do I get to fundamental care in LGS in 15 minutes, right? And this is where she suggested that I share with you how I take care of my families with LGS and how I take care of our LGS loved ones. So the topic of conversation for the next couple of minutes is going to be, what does fundamental care include and how do you know you're getting it? Oh, did I do something? Sorry. Uh, let's see. All right, so our learning objectives for today is going to be to understand what fundamental LGS care looks like today, name the specialists and care elements of fundamental care across the lifespan, and use a checklist or rubric to evaluate the care your loved one is receiving today, and also explore what the future of fundamental LGS care may look like. And at the end, I want all of you to have your phones ready because we're gonna use a Mentimeter so you can identify one action item to share with your neurologist or epileptologist at the next clinic visit. So what is fundamental LGS care? So I'm gonna share with you what care is like at my center. So I am a pediatric epileptologist at Johns Hopkins. So at our center, our patients establish care with a pediatric neurologist or an epileptologist like myself. I know that several of you might be familiar with these terms, but for those of you who these terms might be relatively new to, let me just go over what this is. So a pediatric neurologist is someone who has an MD or MD equivalent degree, following which they've pursued pediatric residency training, which is around 2 to 3 years. And then after that, they have obtained training in pediatric neurology, which is 3 years. An epileptologist is all of the above that we just mentioned for a neurologist, but on top of that, they have done 1 to 2 years of epilepsy fellowship training, in some instances, maybe 3 as well. Okay, so during the clinic visit, when a patient comes to see me in clinic for the first time, if the goal of the clinic visit is a second opinion, my first question to the family generally is, what is your goal? What are your priorities that you want to make sure we address today in the 60 minutes that we have together? And then we discuss, and then we start going into their epilepsy journey together. So we start with the age at seizure onset, types of seizures that their LGS loved one has, their seizure semiology. Several of you may have heard that term, but it basically is a fancy medical term for essentially saying what the seizure looks like externally. And this is where I think Dr. Clark had mentioned that the phones that you have on hand are extremely useful. They are like gold for sure, because many families come to me with videos of what they're seeing of the seizure activity. And when I look at the video, what I usually like to do is before we even play the video, I just hit pause and I'm like, so tell me, why did you start recording your child at this point in time, right? What were they doing? What caught your attention? And then I ask them about how far into this particular event or seizure are we? And then we watch the video together. And as we're watching the video together, I talk out loud about what I'm seeing on the video so that the family and I can compare notes on whether if I'm catching on to everything that caught their attention, so that way we're all on the same page together. And then following this, we then talk about what the post-ictal or post-seizure period was like. Some things which I kind of ask all of my families about is whether if they've noticed any specific changes after a seizure. It's normal for all of our patients, children and adult, to be tired and sleepy afterwards, right? However, what I'm especially curious about is whether if they were perhaps a little bit more weaker on one side of the body in comparison to how they were before they had the seizure. Because if that's the case, that's a very nice clue that can tell me that the seizure activity potentially came from the opposite side of the brain. And then I always want to know about a history of status epilepticus, just to understand how fragile or how brittle our epilepsy journey has been with our loved one. Now, during the clinic visit, our conversation will then, once we go through our epilepsy journey together, a key component is what all medications have been tried, right? So number one, I usually go through what the current medications are, and then go through what other medications have been tried, what the dosages of the medications are, and how effective my families felt that these medications were in helping control the seizures, and their quality of life. And then we also go through any potential side effects and in what doses those side effects were noticed. And in these instances, I think Tiffany had shared how you head into the visits with spreadsheets, and that's when I have amazing families who walk in, pull out the spreadsheet, and tell me that these are the meds that worked at what dose and what the side effects and effects were. So the second thing that we then talk about is whether dietary therapies have been tried. So there are many different variations of ketogenic dietary therapies. There's a classic ketogenic diet, there's a modified Atkins diet, low glycemic index treatment. I'm happy to chat with you guys offline about this. But especially if any of my patients have a G-tube, then the question that a lot of times that I wonder is, why have we not considered the diet, right? Or have you tried it and and the diet has failed you, right? Okay. And then we talk about what type of investigations have been completed. So what type of EEG studies were done, when they were done, imaging. So usually I take this time to bring up my child's MRI and review that together with caregivers, and then proceed to what type of genetic testing has been completed. Do we start with an epilepsy gene panel? Have we done a whole exome, whole genome, etc.? Okay, and at the end of the clinic visit, I usually take a few moments to quickly summarize everything that my families have told me and say that, okay, so to summarize, here's what we just discussed, and then together, we sit together and talk about what the best next steps are. Now, it might be an anti-seizure medication, might be the best next step, perhaps the ketogenic diet might be it, or considering devices such as VNS or RNS or DBS, or surgery. And perhaps there may be a clinical trial that my LGS child might be actually eligible for. But at the end of the day, the most important message that I want you guys to leave with after this talk is that there are always options. Okay, we're never out of options. We will have to discuss the risks and benefits of each option, but we will decide on that together. So there are always options. And at the end of the clinic visit, we then once again re-review our goals and priorities. I've listed here some of the goals and priorities that we generally tend to focus on for our LGS families. So eating, sleeping, our child's safety, school, and I also like to check in on our family members and make sure that my parents as well as siblings of our LGS loved one are actually doing well. And then connect them to resources such as the LGS Foundation, Epilepsy Foundation, and gene-specific organizations. So it truly takes a village and a community to help support the care of our LGS loved one. So going through this journey, I think the message that I really want to relay to all of you is that fundamental care as we take care of our loved ones with LGS is not a specific point. It's not a single checkbox that we're checking off. Rather, to me, fundamental care is to make sure that you feel your concerns are being heard, that you're being listened to, and that you are a key member of the treatment team. There is no way that I can go through that entire clinic visit without your support, right? So this is what a new patient visit looks like in my clinic. So after a new patient visit, now what? We then have routine follow-up with a neurologist or epileptologist every 4 to or maybe 3 to 6 months, depending on how my child is doing. And I'm very fortunate because my clinic nurse is actually also an LGS warrior, like all of you here. So she has a child with LGS and can really relate to my families. And sometimes we're accompanied by a social worker as well. My families keep in touch with me through patient portal at Hopkins. We use MyChart. And we generate seizure action plans as well as sick day plans, and always ensure that we have the updated doses of the rescue medications available. And at follow-up visits, once again, we review not just seizure management, but management of additional comorbidities like sleep disturbances, behavioral difficulties, anxiety, mood disturbances, and involve palliative care at times. Now, as I mentioned, palliative care, something which is very important for everyone to remember is palliative care is not equivalent to hospice care. That is not what this is at all. With palliative care, this is an amazing specialty that can be maximally utilized, can be well utilized in our children and adults with LGS. As we deal with these complexities and multiple medical needs of our LGS loved ones. Yes, and then I already mentioned that we also check in on our caregivers and siblings. Okay. Now let's talk about transitional care. We've heard about, we've heard your voices through all the experiences that you guys have felt. So with transitional care, number one is that we actually start at Hopkins. We start the discussion pretty early. So the transitional care discussions start no later than 14 years of age. And at around 16, 17 years of age is when I have identified an adult provider to transition my LGS, my child with LGS to. And then at 18, 21 years of age is when we officially transfer to adult epilepsy care. The reason why we start so early, and sometimes the families of my 14, 15-year-olds ask me, Dr. Haridas, do you just not want to see us anymore? And that is not the reason why. The reason why is because our adult epilepsy wait list at Johns Hopkins is 6 to 12 months. And so it is very important to start discussing this ahead of time so that way we can make that transition as smooth as possible. The way that we conduct this transition is through email and phone conversations with the adult epilepsy provider. And a lot goes into that decision about which adult epilepsy provider is the right fit for my child with LGS. So for example, if I'm thinking that my pediatric patient surgery would be the next best step, then I'm going to transition them to someone who has a specialized focus in surgery. And when transitioning my patients, I go over what the underlying reason is of their LGS, what their current seizures are like, and relevant past seizure history, including status epilepticus. I give them a list of all the previously tried medications, along with their emergency seizure action plan, and then review what the next steps in epilepsy care is. What I mean by this is that I'm the one that has been taking care of this child for so many years in clinic, along with the amazing families as well. So at the end of, as I'm transitioning, I usually let my adult colleague know that we have tried medications A through X, and now the next steps are Y, Z, and if that doesn't work, then we're going to move forward to let's say a VNS or an RNS. And then also we transition what comorbidities our children have, as well as what their management has been, and of course guardianship, which Jamie had discussed. When possible, we also conduct what we refer to as a warm handoff in clinic. I wish this was possible every single time, but sometimes schedules don't work together that well. But I would say most of the time we're able to have a warm handoff where the new adult provider will come to clinic and introduce themselves during the clinic visit, so that way my families know exactly who to look out for. At Hopkins, I do have to say we are in a unique circumstance where, for us, pediatric and adult epilepsy are under one umbrella. So the transition process can be a little bit more smoother, and adult providers have the ability to walk into the pediatric clinic and just introduce themselves to the families. Now let's talk about adult LGS care. So once my child with LGS has been transitioned to the adult side, a new patient visit there too is 60 minutes, similar to the pediatric side. They too review seizure history, review the etiology of LGS, and review prior workup, the current priorities, and the best next steps. And then establish a working algorithm if a group home is involved, then with a group home, to ensure that we have a clear line of communication, clear idea of rescue regimens, and clear follow-up plans. So our LGS loved one does not walk out of the clinic just knowing that they should follow up in 3 months. They walk out of the clinic knowing what date and time they should be coming back for their appointment. One of the other responsibilities that I was tasked with was to provide a checklist for epilepsy care across the ages. So I'm just going to go through this really quickly. So of course, one step is to establish care with an epileptologist. Make sure that there's been an evaluation of the underlying etiology of LGS. As Dr. Perry had said, LGS is this one electroclinical syndrome from multiple different causes. Sometimes we need to reassess this and ensure that there is an updated seizure action plan as well as a sick day plan for what to do when we're not fully in status, but seizures are gradually picking up, or if our LGS loved one is unwell. Establish that we have a clear seizure safety plan. Consider evaluation for potentially surgical options like such as a surgery device, diet, clinical trials, and then ensure that you are identifying subspecialists for comorbidities and have a transitional care plan, especially looking at ensuring not just you have an adult neurologist or epileptologist, but also a primary care provider, know about the updates for insurance, what the ED plan would be like, in guardianship. All right. After covering all of that, I will say that I just want to leave you with my view of what the future of fundamental LGS care looks like. And this is my glass half full or very full view. I'm very fortunate to work with an amazing group of physicians, and together we're actually working to create a multidisciplinary care team, where very similar to what our colleagues are doing in Texas. What we are going to be doing is bringing together multiple specialists into one room, so you don't have to schedule 6 different appointments, but you go in and you meet all the 6 different providers. And our goal is that this will also help with transitional care as well. And lastly, if I can offer you a little pearl of hope for the future. I know that it feels very dark and dreary some days, especially as you're trying to transition, but there is an increasing interest in adult DEE, in adult LGS care among epilepsy fellows. As the former fellowship director at Hopkins, I have screened through many applications, and I see a budding interest in this, and I think a lot of that is because of the work that the LGS Foundation is doing in increasing awareness and in promoting research in this area. And lastly, to help identify an action item for your next neurology or epilepsy visit, if you guys want to take your phones out and just scan this, I think we should be able to pull up the Menti link. Let me just give everyone another 5 seconds to scan this. I might need to log in here. Give me 1 second. All right. Oh, it doesn't look like, Oh, I'm sorry, guys. It doesn't look like it's coming through correctly. But I will say, in the interest of time, the 3 main things that I'm seeing in the word cloud that you are all generating is number 1, transition. Number 1, seizure control. Number 2, transition, genetics, and sleep. All right. Thank you all for your time. And with that, I'll hand it back over to Renee.